So morning everybody, welcome to our Trust Board March meeting, and thank you very much for those who are joining virtually for showing interest in our Trust Board. Hope you enjoy our meeting. So we can just start the meeting. So if we go to item 1, apologies. I don't think we've got any, Jenny, have we? No. Item 2, declarations of interest. You've all got the paper, and if there are any changes, please let Jenny know. And if there are any items where you need to declare an interest on the agenda, please do so. And if necessary, excuse yourself from the item. So if we could go to minutes of the meeting held on the 24th of February, are there any matters of accuracy that you've not already let Jenny know? No. Any other additional actions that are not on the actions log? No. Well, we'll take those as a correct record, a true record then, Jenny. Thank you very much. We'll approve those. Item 4, the actions log and matters arising. Anything on that? No. Okay. So then if we could please go to item 5, which is the NHS staff survey presentation. So this is instead of our usual patient story or staff survey today. So Steve, over to you.
Great, thanks Sharon. John's doing the screen and I'll do the talking, so thanks John for helping out on that. So quick recap on our staff survey, where we've been sort of cover off a little bit around response rates, how we scored compared to nationally and some of our benchmark groups, highlight a few issues and then talk about some priorities. We had a session at Workforce Committee last week where we looked at what this means for us and some of the work that we're going to be kind of focusing on. As a reminder, all NHS provider trusts undertake the staff survey. You can either do it across the whole organisation or you can do a sample of the organisation. As a trust, we've taken the decision to do the whole organisation for the last 3 years. Across that are 111 core questions that we ask our staff to complete. Of those 111 questions, 49 of those go towards theme scores, and they're 10 themes. And I'll cover that off a little bit later in the presentation. Usually 11 themes. There's usually a question around the quality of appraisals. That was kind of parked for this last year because of COVID, but is likely to be back in the survey for future years. So John, if you could just click over for me, please.
Can you see it, Steve?
It's not clicked for me, no.
Do you have the front page?
I've got the front page.
Just front page for me as well, John.
I think there's just a lag here. I have clicked it, so. Can anyone see the next page yet?
No.
Yeah,
okay.
Thanks, John. So, firstly, just thought we'd cover off response rates. Quick comparison against how we fared last year. So we had a better uptake, which was great, 43% compared to 40% the year before. I think in a pandemic, that's excellent, as we know the pressures that staff were under. So for them to find the time to complete that was good. That's still below the national average of 45% and below our benchmark average, but certainly an improvement for us. We saw high levels of engagement from our managers trying to get to give staff the time to complete this. The data's provided there, some big increases around Lynn's area, and Workforce and OD saw some big increases, and the areas that were high previously, nursing and quality finance, remained high. We pick up in accountability reviews a conversation with the areas that maybe didn't get to the take up that we need, and they explain the plans they've got to increase that for coming years. So if you just click over, John. So just again, quick slide on occupational groups there, just to show the completion rate. So an increase from our nursing and midwifery colleagues, which was great, up to 41%. A slight reduction in our medical staff, and I know that's something that John's picked up and already had some sessions with to try and understand. I mean, again, a lot of this will be driven by pressures and time pressures that people are under, but professional leads get this data to look at how we can increase these rates going forward. Next one, John. So these are the national. This is the national picture. So I mentioned the 10 themes. They're in the table included there. So nationally, we saw 3 increases, 1 decrease, and the 6 remained the same across those theme scores. A national increase in health and well-being, the safe environment around bullying, harassment, and violence. But team working saw a dip in 2020 compared to 2019. So that's the national picture. The next slide will show our scores. So when we look at that, we have a really positive picture compared to nationally. So we saw an increase in every theme score in 2020 compared to 2019, which is fantastic. And within that, there's some data that you'll be able to see the data of the actual score and the 2019 score. But we saw significant increases in health and well-being, staff engagement, morale, immediate managers, and the bullying and harassment, sort of 0.3, 0.4 increases on that overall on the 10 themes. So we've I guess booked a bit of a national trend for the overall scores to what we got. Next slide, please, John. So how that breaks down in terms of questions. So of the questions we asked, 76 were classed as significant improvements, 33 no significant change, and 2 a deterioration. Of those no significant change, actually 31 of those increased. So there was whilst they weren't classed as significant, they did go up. And within those significant improvements, 12 questions increased by over 10%. So some really positive data, and I'll cover some of this a little bit later in the presentation. We've now in a position, and how they class it is positions of strength, opportunities for improvement, and need to improve. And we're at 77 positions of strength now, 32 and 8 for need to improve. Just for some comparison purposes, so last year we were at 69 positions of strength, 41 opportunities to improve, and 12 need to improve. And if we went back a further year, we were actually at 50 positions of strength, 36 to include, and 15 need to improve. So for the second year, we've seen continuous improvement, that a move to more positions of strength, a reduction in those need to improve, and obviously in the middle there, working with the opportunities to try and shift our performance around it. The 2 significant deteriorations I'll cover a little bit later, but they're around musculoskeletal issues and places to go for rest and recuperation. Next slide, please, John. Great, thanks. So a really positive position, and all we can do is work with the data we've got, but not a time to rest on any laurels if we were ever even considering doing so. So when we compare our scores to our benchmark group, we know we've still got some work to do to be average, and of course we want to be better than average, and we want to be in that kind of top quartile. So this slide shows you those comparisons against our benchmark group. That's the 52 other mental health, LD, and community trusts that we're part of, is our group that we're benchmarked against. So we are above average for ED&I, both the safe environment for violence, safe environment for bullying and harassment, and we're average for morale. The other areas are below average, but as you'll see from those figures, in a number of them, only just, we're talking about 0.1% in a number of cases. So we've really narrowed the gap with the scores that we got in 2020. And I'm sure if we continue with the work that we've got, that we'll cover off a little bit later, we'll look to improve on that in coming surveys. So a really positive position overall around themes, but with a recognition that we've still got some work to do to be top quartile for everything, which is obviously where we want to, what we're aiming for. Next one, John, please. So the friend and family test is something obviously that we always look at. It's those kind of 2 killer questions. So would you recommend the organisation as a place to work, and would you recommend it to a friend for treatment? And in both of those questions, you'll see big increases in the 2020. So a jump from 49% to 61% on that question around recommending as a place to work, and a jump from 58.5 to 66 for recommend for treatment. So again, still work to go. We still want to be near the top of that, but a direction of travel that's positive for us based on what we found from the 2020 survey. Thanks, John. Next one. So the next few slides are just some areas just to highlight a few of the questions that obviously some of the answers to the questions that were I think significant areas that we should celebrate, and these will either be because we're near the top in our benchmarking group or because we've shown some real significant improvement. John, if you could just click over, please. So I know that's quite small. Jenny will ping around the presentation afterwards for everyone, but there's 3 questions there that kind of are around experience discrimination or career progression. Or, as you will see, all of those we're above average for, and certainly on 2 of them we are very close to being the top performer on those second two questions. So improved performance and at the top around that, and that kind of correlates to being the really positive scores that we saw overall in the theme for ED&I and the bullying and harassment scores. Next one, John. So for those on the call that can remember when we did some work on our OD diagnostic on an away day a couple of years ago, and we looked at some of the things we wanted to focus on, and we really kind of homed in on helping to improve the capability of our managers in the organisation was something that we really wanted to factor. That was built into our PROUD programme. We invested money in that, and we started to roll that out last year. Obviously, COVID has paused that somewhat, but we've still got plans to continue to roll that out over the next 12 to 18 months. So it was really pleasing to see these are 3 of the questions who are kind of linking with immediate managers about how staff seeing any difference in that. The data would suggest they are, with more positive responses coming back around support you get from your immediate manager, feedback, etc. So for me, starting to see some tangible differences now in how staff perceive their managers in the organisation, taking that forward, and hopefully that's validation to some of the work that we've put in place over the last 2 to 3 years. Thanks, John. Next one. So people may have seen there was a news article I saw yesterday about how many NHS staff thinking of leaving. So these are the questions that would have been picked up from. So the kind of thinking of leaving, looking for a job, leave when I can. So 3 quite emotive questions, really. So we've seen improvements in all 3 of those areas. So again, in a pandemic, in a really testing time, our staff are telling us we've got better scores in those areas than we had previously. So again, still work to do, still want to be average and towards the top on that, but a sense of direction across from 19 to 20 that would suggest that our staff are engaged in that process, and some of the things that we're doing are eliciting a more positive response from them in the survey this year than in previous ones. Thanks, John. So again, just capture a few more around kind of not well enough to come into work and opportunities to show your initiative and suggestions for improvement. So again, big improvements here in hopefully the well-being type questions that we ask about not expecting people to come into work when they aren't well. That's, you know, we've now moved to above average and towards the top around that. And equally, some of those manager type support questions, again, some real positive responses from our staff towards the opportunities to show initiative, and some of the work around the QI program that we have in place. Hopefully this demonstrates that that's starting to come through. Thanks, John. And the final slide on the kind of things that we really want to celebrate will be around health and well-being. So again, we saw investment. It was one of the things that we said in the PROUD programme. We put extra money in the budget to support well-being initiatives across the trust. And again, more positive response there from our staff. I'm going to say it again, more work to do. Obviously, we need to keep that going and sustain it, but that has been perceived and in the survey from staff as being a positive and reflected in the scores that we've had back. And again, there's 2 more questions there around more positive responses around how staff experience their immediate manager, which again links back into that investment that we put in over the last year or so. Thanks, John. So look, there's some real positives in there, and as I say, when you've got so many positive questions across the piece, and picking out areas for need to continue to focus in this section, I've looked at those areas where we still are below that average from there, or we did drop down. So just to highlight a few of those. So again, this is the one where it appears on both. So the health and well-being, so it's positive, it's going in the right direction, but we've still got that gap towards the average. So real continued focus on supporting our staff, and I think particularly when we think about COVID and recovery and how we give our space to our staff to recover from what they've been through in the past 12 months is going to be critical and really important, and we've started that work in the trust over the past few weeks. One of the questions that did go down was around MSK, so that was one of the more negative responses. Again, number of reasons from that we're exploring, but one of the initiatives that we have put in place is signed up to a company called PhysioMed, so we now have a fast track for physio for our staff going forward, access to that which wasn't there in place. So already we're doing some things to hopefully try and address that and shift that performance. And that final one around raising concerns, and again, it's a positive in that it's a more positive score, but we still know we've got a little bit of a way to go to get to the average and towards good on that. Thanks, John. So likewise here, going in the right direction, but some areas around that we've kind of covered off that we still need to keep that continued focus around: the investment in our managers, the investment in well-being, and overall encouraging and doing everything we can to make sure that we retain our staff to deliver the services that we know are so vital and so important. Thanks, John. Three more areas that pick up on the similar theme. Again, I hope I'm not sounding like a broken record. They are going in the right direction on these, but again, we are away from the average on that. So some of the issues around stress, some of the issues around feedback on near misses and errors are going in that right direction. We need to sustain that, but we also recognise that we're not yet quite at the average that where we want to be and up towards that kind of top performing line. Thanks, John. So finally, just reflecting back on those scores. So I mentioned around the kind of must improve, should improve, and from survey terms, that's questions that come under 40%. Or 40% and below. So those are the questions based on the 2019. So I mentioned in a previous slide we had 12 questions that were in that kind of category. We're now down to 8. So those that are in green are those ones where we've improved to such a point where we're now no longer in the 40% or below. And the other areas, so of the other areas of those other 8, 7 of those increased. So we put a real focus on this as an exec team over the last 12 months. These were the things that we wanted to see, so that shift. So it's great that 11 of the 12 have shifted. It's brilliant that 4 of those are now into the next category. We recognise there's still work to do on some of those areas. I'm going to bring Pete in just before I conclude, just to talk about some of the work that we've done on the rest and recreation and food and catering facilities, because there's some excellent work that's been done around that. But overall, again, a sense that these areas that we've focused on are shifting and moving into the right in the right direction. Thanks, John. So look, just overall to conclude, we talked a bit more in more depth at Workforce Committee around this. So what's that telling us really? What does the survey tell us overall? We've checked in with our work that we've got planned for the next 12 months to make sure that we're on track, we're covering the things that our staff are telling us. We've summarised that in that conversation about that continued focus on recruiting more staff. We know we've got nearly 300 more staff working in the organisation than we had a year or so ago. That resetting of establishment and looking at new roles, making sure we use things like physician associates in to help us fill our gaps in our establishment, so that our staff get that break and aren't having to cover the vacant shifts that we've got. We started last year, and I think successfully, and again, Workforce Committee heard periodically from departments about what they were doing or if the department survey results. continued work around that, really getting this down to a local level. How are teams working with their results to shift performance is where we're going to see the greatest need. And indeed, as a result of doing that last year, we've seen some of that bear fruit in the positive set of results that we've got this year. I've mentioned, but I've put on there that continued focus on our leadership and development programs that we've got in place. They're out, they start rolling on. As I say, I'll bring Pete in on the estates and wellbeing in a sec, and that improved and continued improvement around the health and wellbeing offer that we've got to staff. And again, I really sort of emphasise that in a recovery sense from COVID and making sure we're doing all that we can. So Pete, I don't know if you want to just mention, that's kind of my bit concluded on this. Pete, if you want to just come in on the estates, if you don't mind, and then I'll throw it open to any questions.
Yeah, thanks, Steve. So I guess for me, it wasn't unsurprising to see the scores deteriorate in terms of rest space, because at the time of the survey, you know, some of our accommodation had been repurposed to facilitate donning and doffing of PPE, you know, but through the command arrangements, we did complete a programme of works to review donning and doffing and provide additional accommodation where it was needed. I suppose running alongside that, and this is the longer term piece, we have taken by the Staff Health and Wellbeing Group some minimum accommodation requirements for both staff rooms and kitchens, and I think it's fair to say that was well received by the group and gives us something we can aspire to. You know, in the current financial year, we have utilised some of our non-recurrent headroom that we've had in our financial position to facilitate the purchase, if I can even say it, of furniture and equipment. And I guess just to add to that, running alongside that, we have prioritised as part of our 21-22 capital programme continued investment for improving staff accommodation. So, you know, I'm going to use the word disappointing, the score is where it is on the door, but we have got a plan in place to look at those two key areas that the staff survey is telling us, and I'll stop there.
Okay, thank you both very much. Fantastic positive picture, and you know, fantastic. I have to say, in the time I've been at the Trust, it's the best set of results we've ever had, and to see it improve year on year is absolute testament to all the work that's been done. So well done to everybody, and well done to everybody in the Trust. But as I say, in all my years on the board, it's the best set of results I've ever seen. So great to see. As you say, Steve, that's not taken away from the fact there's more to do. We absolutely know that, but similarly, we still need to recognise the improvement that's been done, so that's fabulous. So any questions or comments? No. Oh, Michelle?
Yeah, no, thanks for that, and thanks, Steve. Great presentation. Yeah, just to endorse really what you said, Sharon. I mean, it's obviously a collective community effort. We've said that we're a team, but when you think where we were 4.5 years ago, we were bottom. So you know, I think we just need to remember that. We need to remember the journey that we've come through. We were bottom in nearly every single of the 112 or whatever they were at that particular time result. So we've still got a long way to go, because sometimes 40% for me is still quite low, but we need to build on that success. So I think it's important that we look at the areas where we need to improve and continue, but we also need to continue to do the areas that we're continuing to improve on as well, so that we maintain that journey. Because I've always said the organisation is on a journey, and we are doing that. One of the things that Steve alluded to, we will pick up this later when we get more sort of detail, is that I've just commissioned a big piece of work in relationship to our workforce recovery programme. And that links into Steve. Thank you, Steve, has accepted the SRO baton on that one, and we're going to second probably maybe one or couple of staff into working with the Health and Wellbeing Board, and proud to start to link together to do some really meaningful work around what we mean by staff recovery. As we go into the next few months, because I think we have done a lot of work to acknowledge and value staff, because our staff are our greatest asset, and we'll continue to do that and say thank you and do the appreciation and the gifts and what have you, that we need to do some real big pieces of work around recovery. So we're just planning that at the moment. So certainly within the next few weeks, Workforce Committee via the executive team will see that programme and that plan, and obviously we'll keep the board involved in that, but that's the next big piece of work. But thank you, more work to do. Great presentation, Steve, and we'll continue to support this, because for me it's a really good recruitment tool, because we're doing a lot around, unbelievable campaign and our recruitment. If you've not got a good CQC score or a good staff survey score, then it's really difficult. So we have to use this from a communication point of view to tell folk out there that come and work at Humber, because we are continuing this journey. And I'll leave it there, Chair.
Thanks ever so much, Michelle. So I've got quite a few hands, so I'll work my way down. So Mike Cook.
Thank you, Sharon, and really good presentation, Steve. I really enjoyed that, and we had a really good discussion at Workforce, which I'm sure Dean will cover. But for me, I think the staff survey is of particular note for this year. And it shows that real step change. I know you were disappointed in the last one because there was so much effort going in. You're now seeing the results. That will continue. And I'm already hearing your proactive approach to what else we can lock in, the strengths, and address some of the areas we want to crack on with. Staff are noticing. What's great, though, is that the patients will notice. So there's sometimes a lag. When you see this staff, real engagement, it's actually support, engagement and cultural shift we're seeing. I'm really proud of you all. I think you all need a big pat on the back in a difficult year. I think thanks to Steve and his team, as John said at the Workforce Committee, for getting this taken seriously and authentically. So let's distribute it, let's use it productively. In the context of what is now a strength of the organisation, which we need to keep working. Well done, everybody. Thank you.
Thanks, Mike. Francis?
Thanks, Sharon. And Mike's said a lot of what I was going to say in terms of, fantastic result. It really is a credit to everybody involved and the whole team in getting us where we are, and that change over the last 12, 24 months. I was just going to pick up on two things. Obviously, it is now slightly historic. And whilst we had one of the things we discussed at Workforce is whilst we had a really good increase in the number of people, when I say increase in an improved score, not an increase in the number of people thinking to leave the organisation, obviously we've had a lot more pressure of COVID since then. And we had a discussion around keeping on top of that. And giving people space for recuperation as we come out of COVID, because that figure might have changed for everybody in the interim between this survey being done and now, because of what's gone on and the pressure the whole NHS has been on. So we did have a discussion around that at Workforce about trying to keep on top of that.
Thanks, Francis. Peter?
Well, thanks, Sharon. Yeah, it's all been said really with what I was going to say, but I think you and I, Sharon, have been here longest in terms of board members. I think this is the best survey result that we've had in our history at Humber. So really well done. And I think that one of the step changes that I've noticed is communications. I think the comms department deserve a lot of credit, and the way the website's been developed and all that makes people, staff, governors, everybody feel more part of it. And I think, despite the fact that we've been in this virtual world, I think I'm really impressed with the visibility of the team, especially during this pandemic. And I think that's reflected in these survey results. So really well done. And just to remind, just on staff wellbeing, health and wellbeing, that there are charitable funds available. One of the slight negatives, perhaps, in the last few months has been a lack of wishes coming through on the charitable funds. So I think perhaps have a bit of a refresh on that in terms of wishes coming through that can be used for staff health and wellbeing. Would be a suggestion that I might make. So, but well done.
Thanks, Peter. And I think that's a really good suggestion, actually, which I'm sure Steve and others will work on. But no, that's a good point, I think, Peter. Thank you. Mike Smith?
Yes, thanks, Sharon. Same comments as everybody else, particularly around communication, but how fantastic to have achieved this during one of our most difficult years. Just a slightly different perspective from me about implementation and about the feet on ground area of estates and procurement, because some of the rest and recuperation stuff could be as simple as a broken tap or a blocked sink or a kitchen cupboard door falling off or whatever. And some of it will be more extensive, but there's a real opportunity here while we've got the cash to do some things this year. But that means that the concomitant drain on resources is there. So to actually release that, have we got enough feet on ground in the States to have a real push? Have we got enough people in procurement to use the local supply network and use our role as an anchor? You know, I'd like to get some assurance, if we can, that we'll actually make it happen rather than budget for it.
I suspect it probably forms part of the work that Michelle gives.
Yeah. I mean, it's not a blame question. It's definitely an assurance, you know, and you know, keep up the good work and tell me all about it.
No, that's great. Thank you. Pete, did you want to respond to any of that?
Yeah. So I guess in terms of capacity for estates, the workforce plan is obviously, we're in the thick of doing that, and that has reviewed the capacity to be able to deliver what is an ambitious capital programme next year, some of which will be supporting the recovery work. Running alongside that, we do utilise partners, so we have the ability to bring in resource, which indeed we're using at the moment to support us on a couple of projects with the Strategic Partnership Agreement and City Care. So, you know, we do have a resource there where we can bring in non-recurrently. And for procurement, I'd have to go back and look at that one, but we have strong supply chains as it stands, Mike. So I wouldn't expect that to be a particular issue.
Thanks very much, Pete. Okay, well, thank you. Some really positive comments there. And the other thing I'd like to say is we did discuss at Workforce, and I've seen firsthand in the Staff Health and Wellbeing Board and also my conversation with staff, the other big change to me over the years has been the ownership of staff and the desire to get the results and actually work on them and look at which areas need improving. And that for me has been a massive cultural shift over the time that I've been on the board, and a real change. And you really do see it in action when you're in meetings with staff and others. So again, that's another fantastic achievement, I think, because that's not easy to do, and that does take time. So you can really see that live in the trust now, that this isn't just something that's presented to the board and put in a drawer. This is owned by everybody. So well done for that as well. So great start to the meeting. Thanks, Steve, for putting that together and for presenting. Really good presentation, and well done to you all, because it really is good news. And you know, it's taken a lot of work, and it is appreciated. So thank you very much. So that's fab. So we'll move on then to item 6, which is my chair's report. Always a busy month. I've continued with various meetings. I've met with Richard Barker since the last board meeting, who's the regional director. Also had an interesting meeting with Kath Lavery, who's the chair of Yorkshire Ambulance Service, just to discuss working together. Continued with Humber Coast and Vale meetings, and also health and wellbeing workshops, and Michelle presented at the last one, so that was really good. Led on mental health with Emma Delamore from Mind, so Michelle did a very good presentation to the Health and Wellbeing Board. Internally, it's been really nice to meet with some of the teams and some of the staff. So I've met with some of the speech and language therapists, for example, just to catch up with them and hear from them how things are, how it's been in the pandemic, the good and the things that they'd like to work on. And in my role as Staff Health and Wellbeing Guardian, I have attended the Staff Health and Wellbeing group, and I think Lynn does give a bit of an update and has done, but it's great to see them owning the plan for what's intending for the year, and they're really keen, I'm sure Lynn would back me up on this, to use the staff survey results to inform their work and look at what needs to be priorities for the next year. So that was very encouraging. Also attended the patch-wide patient and care experience group, which was very well attended, hosted by Mandy and her team. And it is great to hear from patients and carers as to how their experience of trust services has been. So that was very positive. Governors remain active, and I've had a very good introductory meeting with the new East Riding Governor, who'll be joining us soon, and continue to meet with individual governors and governor sessions. And we had a really good session with the governors on our community services and the pathways for patients, which the feedback from the governors was really positive. So thank you to all of you and your teams who took the time to pull that together for the governors, because it was really appreciated. So I think I'll stop there unless there are any questions. No? Thank you. Then if we could move on, Michelle, to item 7, the Chief Executive's report.
Thank you, Chair. Good morning again, everybody. You've obviously got sight of my report. As usual, I'll pick a couple of things out and then throw it open to my colleagues and questions. Flu certificates have been distributed to everybody who took part in the vaccinating, that were peer vaccinators, just as a thank you, because if you remember, we did that really quickly. We truncated it. So I hand signed all the certificates of people who did the peer vaccination. We are at the moment in the process of doing something similar for everybody that's worked at the COVID vaccination centre. That's not just the peer vaccinators, but all the volunteers as well. So more on that later. We're just starting to distribute those, the badges and the certificates, etc. But again, that's been positively received. The staff thank you. So if you remember, we've tried to do something every month over the last year just to say thank you and you are appreciated, and we know it's exceptionally difficult. The annual leave day, the friends and family birthday, has gone down exceptionally well with staff. I've had some really positive feedback, and in fact over the last couple of weeks, I think whether it's because it's around the anniversary, I've had some really nice letters from staff who have just saying, thank you, it really is appreciated, keep up the good work, which is really positive. To be fair, it's really nice. Staff don't have to do that, they're busy enough, so that's really positive. And as I said, we've done a couple of things for the anniversary. Obviously the anniversary was on the 11th, which was when the pandemic was formally declared. So we did a video, so it is attached to the link. So please have a look at that. It's a really good video. And again, I thank Comms team for that. We've now got a really good library of videos, but that just shows you what it was. Little snippets throughout the year. We did the day's reflection on the 23rd, the silence and then the hand clapping at 8 o'clock. But we've also we also used it to relaunch our book. If you remember, we published a book, so we've relaunched that with a few more stories in there as well. Fantastic news about the website. Remember, we developed that in-house, so absolutely. I know Adam will be getting fed of me saying well done and congratulations, but we did that internally ourselves, and I thank Adam specifically and the team, and we got a fourth rating. I think it should be a first, but fourth I'll just about settle with. But no, seriously, that is really, really good news, and I think it is a really interactive platform, and obviously we'll continue to do that. Great work on the youth board that's developing. And thank Mandy and the team for that, because it's really important that we look and really start to listen, well, not start to, but continue to listen to our younger community and service users and families, etc. I've noted the white paper at the moment, the timetable for going through the house, and obviously the integrated care system work is developing. I'm still leading the provider collaboratives. Suffice to say that we are really quite well ahead in Humber, Coast and Vale with the provider collaborative work, but that is really quite a big piece of work. Social values, obviously the work that John brought to the board a couple of months ago, that has been launched as we agreed in April. I think it's about the 19th of April. We continue to roll out our brand. We continue to do the recruitment campaign. We are distributing at the moment Easter eggs. Everybody that went to the vaccination centre got a little Easter egg anyway, but we're doing what we did last year and send out Easter eggs to everybody. And again, can I just take this opportunity just to thank the volunteers, because volunteers do so much in the organisation. They are just such a fantastic group of people. So they're distributing those as we speak. So thank you for that. There is a MAPA report, annual report to note, and the COVID and the vaccination will come up later. So I spent some time in the vaccination centre working there this week, and that was really, really exciting. And again, I thank John and others for the work that they've done in relationship to that. I continue to dial into loads of team meetings virtually and see staff virtually, and I think we are still getting the really high morale, staff being relatively settled, obviously tired. And that's why we're looking at this long-term recovery programme in relationship to Recover, Restore and what it means for staff. So we'll continue that. And lots more in the report. We're also planning the Chief Exec Challenge again for this year. We didn't do it last year because of COVID. So we're continuing to do that this year. And we'll press ahead with that, and that's to raise funds for health and wellbeing for staff. So thank Health Stars for that. So Health Stars and Comms report are in there. I know Michelle's got a hand up, but I'll pause there, Chair, and throw it open to questions, or if Michelle wants to mention anything at this point.
Thank you, Michelle. That's great, and there's so much in the report, isn't there, to cover so much positivity really as well. So much going on, which is fantastic. And we will, of course, look forward to hearing what challenge they're going to make you do this year, and maybe come along and help you a bit. So, Michelle Hughes.
Thank you, Chair. Just two things. Firstly, the communications report is there, and again, as usual, it's supported with performance data. But just to highlight two quick things, the GP practice websites, they've been reviewed by the team working with colleagues, and an up-to-date website has been developed, which is great news and perhaps long overdue. And secondly, just to highlight the number of PR campaigns and the media interest, 25 positive news stories in month, which is a huge amount given everything else we're dealing with. And just secondly, the trust policies, there is one policy that was approved after this paper was prepared. The Workforce and OD Committee approved the apprenticeship policy, which board is asked to ratify today in order for it to go live on the 1st of April.
I think it's the relocation policy, Michelle, isn't it? Or is it the apprenticeship policy? I thought it was relocation, but as well. But we can pick. Should we pick? Can you just check that while I take other questions?
The relocate, Steve. There were two.
Yeah,
I've just
come
seen
in, Sharon. So
yes, please. Sorry.
So we agreed the relocation policy was agreed at Workforce Committee, so that one's in there for ratification. We agreed the apprenticeship report virtually through the committee at the back end of last week because we'd had an agreement from our staff side, which was fantastic. So we also just want to ratify that one today as well. I'd sort of liaised through Mike, Dean, and Francis as the committee members on that item.
Okay, so there is two to ratify then. Okay, so do you want to take those? Should we do those now then, Michelle, or do you want to wait till we get to the workforce assurance report?
Should we take them now, Chair?
Okay, that's fine. So are we happy to ratify the apprenticeship policy and the relocation policy? Any dissensions to that? No, thank you. They're duly ratified. Thank you, Michelle. Francis? Thank you, Chair.
Just a couple of well dones and a few questions. So I was going to pick up on the Trust website and the also the ones for our GPs, which is excellent, and it kind of links to Peter's point earlier about the improved communication and what a great job the comms team were doing. I also picked out, I really thought the work on medical students, volunteers was great. The High Sheriff Award, obviously. The work at Parkview on being more timely in terms of discharge is really good work, and the student placement. So again, some really positive stuff, which was great to read. In terms of questions and just comments, on pack page 31, which is the bit around the mapper, just a request for me, if allowed, I wouldn't mind sitting in. It talks about the video conferencing, allowing staff to learn a bit more about the mapper process. If it was allowed, I wouldn't mind sitting in on one of those myself just to see how that works, if that would be okay, because it would just be useful for part of my training and development. On pack page 33, the HSE hospital spot checks, I was just going to say that if it was any help, if anybody needed a chat, there was one of those done actually at Barnsley. I was there when it was done at Barnsley, so I was part of that process. So if anybody wanted to have a chat about that, more than happy to help out in terms of that. In terms of the vaccinations, we heard from John at Workforce how well that was going, and again compliment the team on how well that has gone over the last couple of weeks. In terms of the financial wellbeing webinar, focusing on your financial health, again, be interested in sitting in on one of those if it was deemed okay, just to understand what's in there and how it works, just as a quiet observer at the back end of that. That would be fantastic if I could sit in on one of those and just hear what is going on. Corporate accommodation, I thought there was some good work mentioned in there. I just wondered who was involved in the staff engagement and participation stuff. Which staff have we got involved with that? Because it sounds a really interesting project. And that was it from me, Sharon.
Thanks, Francis. And Lynn's already put in the chat box that she'll pick up about the opportunity for MAFA with those that are interested. So we'll do that. And Pete, if you could also have a conversation about the financial webinar on the same basis, that would be appreciated. So do you want a response to your last comment then, Francis, about which staff are involved? Oh, he's gone silent.
Either now or later. Either now or later, Sharon. It doesn't have to be now. I'd just be interested.
Okay, well, if we could circulate that outside the meeting, that would be helpful, if you don't mind. If we could send that to Francis, that'd be really helpful. Okay, anything else on this? No, I don't think I've missed anybody. So thank you very much for that comprehensive report. Michelle, has been said, lots of positives in there, so really good. So staying with you, Michelle, item 8, the publications and highlight report.
Yeah, thanks, Chair. Again, everything is included in the report with the publications that we've had in over the month, with the lead director, and a little bit about how we're dealing with that in the organisation. So I'll just leave it there, Chair, and if there's any questions on any of the papers, then please, I'll try and answer those now.
Thanks very much, Michelle. Any questions on that paper? No, thank you very much. If we can move on then to item 9, the performance report, Pete.
So this is a performance report as at the end of February. Usual format with commentary for indicators outside of normal variation. I'll mention cash because obviously that's in my portfolio, which has gone up in month, and that's due to additional non-recurrent funding and the settlement of some aged debt, which is positive, and also reflective of the fact that we are hosting some of the non-recurrent resources that have been released, most recently things like delayed transfer of care funding, etc. You'll see the separate appendix in the paper on waiting times, and obviously we've included some information from the Safer Staffing dashboard in the front of the report. So I think it's best if we move to questions.
Thanks, Pete, and also thank you, Lynn and others, for the waiting list report. Very helpful. Any questions on the performance report? Peter Barron.
Yeah, and I think it was really useful to have the information at the front on the dashboard. That saved a couple of questions. Thanks for that. I just wanted to ask about the vacancies at Malton, because we've only got 23 or 24 staff at Malton, but we seem to have 6.5 vacancies at the moment. I just wondered really what the situation was. Why is that so hard to recruit at Malton? I mean, it doesn't seem to be inaccessible or anything like that. It's in a good area. And how does that relate to sort of safer staffing?
Thanks. Hilary, could you perhaps answer that?
I believe they have recruited some more registered nurses since this was done. They're obviously going through the recruitment process at the moment. This is a big focus for Collect, our recruitment nurse, and Julie Taylor to work with Malton. It does seem to be difficult to get nurses in that area because York Hospitals tends to pull the registered nurses. It doesn't appear to be affecting the quality indicators around safer staffing too much. Obviously, they've got bank staff coming in and they're working flexibly. If you look at all of the indicators that we're looking at, predominantly green. There's a couple of ambers in there, but given that we're also still in the pandemic at this time, this is January's figures, so we've got a bit of sickness in there as well. That unit has had a lot of investment in it. It's had a lot of leadership training put in there and quality improvement work done with that unit, which again is paying dividends. And I think sometimes when you do that and you focus on an area, some staff leave, which will have impacted on those vacancies we've got as well. But my understanding from talking to the clinical lead in that area is that we have got recruitment in that pipeline now as well, which again, when we get the international recruitment nurses coming through, which we hope the first cohort will arrive hopefully in June, they will be working up at this end as well, so they will come straight into that division, and will more than likely be working in the inpatient units, certainly to start with, until they feel their feet. So again, we've got that in the pipeline too. I don't know if Lynn, you wanted to add anything further from the vacancy point. You might have a more up-to-date picture than I have.
No, just to say we actually have been successful at Malton, but those additional nurses are not in post yet. But I just concur with what Hilary says. Actually, we have a bespoke recruitment campaign around this particular patch, because it is difficult to recruit there, unfortunately, as well. But Hilary, you'll know that we've been doing lots of work, particularly around nurse leadership too, in that area. So I think there's opportunity for us to focus on those real opportunities that we have across Malton and Scarborough and Rydale around sort of, newer type of roles as well. So whilst it's difficult now, there's a lot of workforce developmental work taking place, supported by Colette. So I think we're doing all the right things to address that issue.
Thank you.
Thank you both for that. Francis?
Thanks, Sharon. Just picking up on the appendix, which was really useful, and thanks for that on the RTT and waiting times. Just interest again on the BOSA brief observation. I presume that is good news that we've got that. I just wondered how that worked. And then your other point about Helios, I was just wondering how much of the backlog they could pick up, what kind of percentage they could pick up. So just 2 questions on that.
Sorry, Francis, didn't quite catch your first one. It broke up a bit for me.
Okay, so the first one was around BOSA, the brief observation of symptoms of autism. It sounds really good. I just wondered if you could just give a little bit more information on that and how we can make use of it, because it sounds like a good approach. And then the second one I think you got, which was the Helios bit.
Yeah, I did get Helios, yeah. Yeah, so on the first one, Francis, obviously we're doing everything that we absolutely can to optimise the autism pathway. So obviously that's been very much part of it. So it really does help us sort of give that sort of, focus on sort of the clinical standard around that. So over the last month, I think we really have pulled this pathway apart in its entirety with the support of the clinicians in the service. So Helios we've utilised in the past and certainly over the last year. So we've doubled the capacity around that, and we've also looked at the Helios do focus on I wouldn't say the less complex, but they probably are in that sort of mild to middle sort of range of complexity. So we've looked at the upper end of the pathway too. That means from March, from this month onwards, in terms of first appointments to commence diagnosis, we've doubled the capacity overall, utilising Helios and utilising our own staff assessments as well. So it's disappointing we've not seen an improvement in the February data, but I am optimistic going forward. We should see that improvement start to happen in the March data. I think as well, Francis, is always, really important that we continue not just to look at what we're doing. So I think that comment in the appendix as well around the work that we're doing with our system partners around this is absolutely crucial. And I think a couple of months ago talked about, and I think Michelle's mentioned it in her report today as well, the introduction of the mental health support teams in schools, which is just being implemented from now. And I think that really is sort of starting to look at the prevention end of the pathway, augments the work that we've already done through obviously our other sort of input into schools too. So I think the combination of the changes that we're making, some system changes that really should, when they are in a position to have impact, should really help with this pathway. We've also taken the opportunity over the last month or two to talk to other trusts about the impact of COVID on their services, to understand what we can learn in terms of, managing the demand that everybody has seen nationally sort of increase in relation to autism diagnosis in children. So I think a combination of all of that work, I think it's very difficult to see what more we can do. There is opportunity to utilise Helios as well further. And obviously the outcome measures in relation to Helios are really succinct, and we can see very quickly what the impact of that is. So I think it's a combination of all of those things, which hopefully comes across in the appendix that you've got.
Thanks, Lynn. That's very comprehensive. Can I just ask, it's not directly linked, but obviously there was previously a focus on adult ASD, which is mentioned just briefly in the report. And I know a lot of work's been done, but do some of your comments apply to that? Because obviously the figures have still gone up this month, despite that work. I mean, only small numbers, I do accept, but it's still going in the wrong direction. So what's the situation with that one?
It's very similar, Sharon, so everything that we've learnt around the children's pathway, we've applied to the adult pathway too, as you would expect. There's a lot of citywide, again, particularly in Hull, focus on these pathways, both children, young people and adults, in the neurodiversity work that's referenced in the paper too. So that really is right across the age range. And again, it's a similar position around adults as well. What are we doing, you know, further down the pathway to prevent, you know, people having to come through for us for diagnosis, when actually we can put the support in place that's needed sooner. So again, working very closely with local authority colleagues, particularly around that.
Thanks, Lynn. And just finally, if you just briefly give us an update, if we haven't already put it on, just on the CAMS waiting list.
Yes, so actually there's a bit of a mixed picture around CAMS waiting list. So core CAMS in the main is actually going in the right direction and is improving. However, there's a particular pressure, particularly around eating disorder referrals and particularly in East Riding. So again, we're looking at with the commissioners what more we can do to augment that pathway further, and Michelle will comment as well. Again, we're not alone in that. That's a national pressure and it's an ICS pressure too. So there is a dedicated work stream that Michelle is leading within our ICS to look at what more we can do, certainly working together and where we need to invest to address that sort of need, which so the CAM surge, it's obviously referenced in my COVID report as well, is really one of those pressures that is really significant, probably the highest pressure that we've got across our system at the moment in terms of mental health demand. So huge focus on that, what more we can do in the community particularly, but also looking at sort of the inpatient end of eating disorders too.
Thanks, and Michelle's got a hand up. Michelle?
Yeah, thanks, Lily. Just to pick up and expand on that from a systems point of view, that the child and adolescent is a real regional and national issue. It's been well known for the last couple of months. There's just been no national beds anywhere. So we've got obviously a real flow and pathway issue, because we know that the children and people in the community are really quite poorly and they've got quite high acuity. So actually do probably need some sort of inpatient intervention. So we're working through that as a system, as Lynn alluded to, but also nationally. As you know, we've in the planning guidance, which we'll come on to, was published last Thursday. We know there's going to be an extra 500 million for mental health services, which is circa in Humber Coast Vale about 18 million. And one of the things with my overall systems hat on and lead on, I'm earmarking some of that for children and young people, because the demand will continue to rise. The issue we've got, and we picked it up on a national call on Friday last week, is the workforce aspect, because we can have the money, but where we're going to get the workforce from, because they are so specialist. So we've got that conundrum to work through and we're talking through as well, which is why we're trying to do as much mutual support in Humber Coast and Vale as we can. Suffice to say, I think we're not in the worst position. But we do need to really have some robust plans, and I know we've got some, but we need to continue to do that and work collectively, because I think the only way we're going to solve this is working collectively together with the providers and including the local authority, because a lot of the children and young people come from the local authority, either from the looked after system or known to the local authority, etc. So we need to really concentrate on that, but I'll stop there.
No, thank you. That's helpful, and it's good to see the focus from obviously the trust and the system, because I mean there's a lot of people on these lists, aren't there? And these are people at the end of the day. So you know, it's them and their families. So great to hear that there's a lot of focus on it. And I know it's not an easy solution, but really important. So thanks for that. Are there any other questions on the performance report? Can I just ask one, just on the early intervention in psychosis, and this is on page 94. It seems to be quite a drop. So if you just wondered if you can explain to me what's happened there.
Yes, I can, Sharon. As you know, obviously the drop had been more significant. We've got a recovery plan in place. That recovery plan was going very well. Unfortunately, you're probably aware it's actually quite a small team, the early intervention team. So unfortunately, we had 2 members of staff be absent. That was unexpected. We have obviously remedied that, but that took sort of a few weeks to find additional resource to add to the team. It is also in a backdrop as well of increasing demand, not to the degree that we're seeing in CAMs. So again, we've got a good piece of capacity and demand work that we've done around that, but being 2 staff down in a small team did have impact, unfortunately. So we are recovering that now with additional support.
Thanks, Lynn. That's really helpful. And just one final question. This is for you, Pete, just on the finance. Just obviously, you've said that the cash in the bank is inclusive of obviously the block payment and capital. How much was the capital element?
Oh, I'd have to. That's technical, Sharon. I'd have to do you a post. Well, can I do you a note?
Yeah, absolutely. If you could just, in fact, just send it round everybody afterwards, just so we have a handle on how much is actually the block payment and how much is actually capital. Thanks, Pete. Mike Smith.
Just on that point, Sharon, I have raised that before, Pete, and we did go through a stage where we had that figure and they seemed to drop back round. I'd like to see that each meeting, please.
Yeah, okay, Mike, that's a fair point.
Thanks very much. Well, thank you for that. Some good discussion there, I think. So if we could move on to item 10, which is the finance report, please, Pete.
Yeah, so thank you, Chair. So again, finance report as at the end of February. You'll note from the report we're continuing to record a break-even position to the end of the month after remove allowable exceptions, and we remain on track to hit our financial targets for the year. I can pull out just a few key points in the paper. So our COVID expenditure, including the income top-up we received, totals 13.2 million year to date. Cash in the bank we've already discussed, but just to highlight part of our movement in cash in the bank, and you'll see it on the balance sheet analysis, is we have seen some progress finally on some of our age debt, and that's been in particular with East Riding Council and East Riding Clinical Commissioning Group. And I think I'll stop there and just I'm happy to take any questions, Chair.
Thanks very much, Pete. And obviously we've already taken as an action for clarity on the capital amount. Any questions for Pete? Peter Brown?
It's not so much a question, it's more an observation. Really. I mean, this is a really good financial position that we're in, and I just wanted to make sure that we fed our good financial position into our strategy refresh and maybe our estates strategy refresh as well, just to see, given that we're in this good position, that we can perhaps improve matters for our staff and our patients. Really get the benefit of this financial position into our strategy and an operating plan as well for 21-22. So I think perhaps we need a session on that at some point.
Yeah, I mean, I think it's a really good point, Peter, particularly on the estate strategy refresh. The position will help. I think we have to be reflective that some of our benefit this year has been reflective of the financial architecture. And in terms of the operating guidance, I mean, we'll take that up a bit later on the agenda, but we've only got an allocation for 6 months, and dare I say, I mean, I'm in a public meeting, but I don't think it's any hidden secret. There will be some level of austerity coming our way, given the response to the pandemic.
Yeah, thanks for that. I think Peter's point's a good one in, though, isn't it? That it needs to feed into those discussions that we're going to have, and perhaps we can pick it up. I know there's a paper, isn't there, on strategy refresh on the agenda later. But it's a good point, Peter. We'll make sure that the finances are played into it and the cash in bank, etc., played into the refreshes that happen. Is that okay, Peter? He's disappeared, I think. So no, that's good. Is there anything else on the finance report? No, thank you very much for that, Pete. If we can move on to item 11, which is the subcommittee chair's report. This is the report that Jenny helps me with. We just bring once a year, just for good governance purposes, to just reflect which non-execs are chairs of which committees. Any questions? No, thank you very much. Item 12, which is the Quality Committee Assurance Report and December minutes. Mike Cook. Is Mike with us?
I think he's gone, hasn't he, Sharon?
I think he might have gone. So, Mike Smith, would you mind taking this item, please? Well,
I wasn't expecting to present this item, but if we can take it as read, and I'll try my best to answer any questions.
No, thank you, Mike. It's just the other Mike has left us, I think. So
Yeah.
any questions on this? And I'm sure that, or Hilary or John, have you got anything you'd like to particularly add?
We love the autism strategy, by the way.
I think it's coming to the board, actually,
It's
the next board
month.
meeting.
Yeah. That's next one. Mike did give an overview of this at the last board meeting, didn't he, verbally? So this is just really the report that just backs up what Mike said. Yeah,
no, that's absolutely fine. So, oh, there's Mike now. He's obviously had a connectivity appointment. Mike Cook, sorry, I know you've obviously lost us, and we're just on the quality assurance report. Mike, is there anything you would like to particularly draw out? No, well, I think, as you say, Hilary, we did have a verbal report from Mike and yourself at the last meeting, so this is the written follow-up report. So thank you very much for that. If we can move on to item 13, the workforce.
Sorry, Sharon.
Oh, no, hi, Mike.
Connection problems, I'm afraid. Just to say, it was a good meeting, and I'm sure it's been said by Hilary and others. We did report in, and I think I'm really pleased with the way quality is working. I think if you look across the trends now, particularly on the workforce, we're getting really good all-round performance, and you know, it's really good to see the last series of reports, including the staff survey. I think they're all connecting up. The money's there. This all-round broader performance is impressive. So well done to all the execs, and that comes through in the quality, the prevention of infection, the COVID resetting up the vaccination centre is terrific, and it's such a great message to staff and to our partners. So well done.
Thanks, Mike. And as I say, I think we've got the autism strategy coming to the board next month, so we'll look forward to that. It's an excellent strategy. So thank you. So if we can move on to item 13, which is the Workforce and Organisational Development Committee and January minutes. Dean?
Yeah, thanks very much, Chair. The report's there, and happy to take any comments on that. I guess just pulling to the forefront of some of the sorts of highlights. We had good reports from all the sort of assurance subcommittees that we got in terms of progress that was being made and the engagement of people in those particular groups as well. We got the insight report, which we have been honing and refining over the last number of months. So there's a sort of narrative section in that now, showing us the commentary of what's going on, as well as a lot of data. And I suppose just relating back to the staff survey results. So not only do we get results from staff, this is our opportunity to look at sort of data and trends that are happening and sort of triangulate some information there, which I'll touch on in a moment. But we got that sort of information through. We did have the update on the staff survey, as Steve had said earlier, to go through that particular area. And then what I've just included in this particular report is just some of the trust performance on a range of measures over the last sort of year or so. So looking at things like turnover and sickness and disciplinary cases, equality, diversity, inclusion, and you can see some positive trends in all of those in the table there. So the committee noted that a lot of that had been achieved in an exceptional year, sort of during COVID as well. So just a bit of further information to link in with the information we received on the staff survey. So positive things on there. And then, as Steve said, we did approve the relocation policy, and the apprentices policy just hadn't been to the trade unions at the time of the committee, and we've considered that afterwards and sort of approved that, which we approved earlier on in the meeting. But happy to take any questions on that. Thank you very much.
Thanks, Dean. Steve, is there anything you want to add?
No, Sharon, nothing to add. No, I think Dean's covered it all. Thank you.
We've got Peter Barron.
Thanks, Sharon, and thanks, Dean. I love the fact that you've got this table in here. You know how I like to see progression expressed in a table, which I thought was very, very helpful, and it shows the progression really nicely. So thanks for that. I just wanted to ask a quick question on relocation policy. I know we've just agreed it, but in terms of making sure it's fairly applied, because I'm aware that we've got a couple of people, very senior people, relocating from Scotland, later this year, I think. And we've also talked quite recently, last few minutes, about international recruitment, filling some of the nursing vacancies. I just wondered how, in terms of that sort of scenario where there's these relocations, how is it managed fairly, such that it's evenly distributed in terms of the relocation allowances being handed out?
You must have been a fly on the wall at the committee, I think, Peter, because I attended that committee as my usual, going round all the committees, and it was discussed. So, Dean or Steve, would you like to just elaborate for Peter?
Yeah, I suppose just to reassure Peter in the first place, it was picked up because there's the two different sorts of levels as a sort of basic and enhanced, and there was just a question about how we make sure that's sort of fairly applied. And what we'd asked Steve and the team to do is just sort of keep that under review as requests are coming in, and sort of keep an eye on what's happening, and then report back to the committee appropriately. But Steve, I don't know if you want to add any more to that.
Yeah, sure. I think two critical things, I think, Peter, really. One is actually previously our policy only applied to doctors. So actually what we were only applying it to a certain part of the workforce. So this now means that we can apply it across to all the roles that we believe need it. So it's very much targeted around those hard to fill roles that we know will benefit from widening our range and helping people to move. So I think the very nature of that change has opened it up. I think the other really key thing from a fairness and equality point of view, taking the point that Dean's made around the two schemes, is there's an expectation on the manager that they've set the level before they advertise. So what we don't do is get into a conversation where we start it as part of an auction almost effectively with it's done before. So whichever scheme you're going to use, you've decided beforehand, and the percentage that you're going to use is decided beforehand and then applied to whoever is successful at that particular stage. And again, I think that's quite, from a transparency and governance point of view, it's a really important point to make, that this doesn't then become something that can be kind of negotiated as part of your joining us. So so I think there are two key bits, Peter. As I say, I was questioning on this in the committee around the two schemes, and we'll make sure that we monitor uptake on that and how we roll it out. And some of the proof of the pudding will be how much we use it and whether it keeps helping us trying to eat into those hard to fill vacancies, really.
Yeah, that's very useful. Thank you very much for that.
Yeah, thank you. That's really good. Okay, so if we can move on then to item 14, which has got a very long title, so I'll just say it's the Commissioning Committee Assurance Report. Peter.
Okay, thanks, Sharon. I mean, we had the board session on the 18th of March. I don't think there's been too much progress since then, but in terms of the way the committee is working, I'm really impressed with the way that the papers are so. The quality of the papers so early on in a new committee is really good. We've got the managers are coming through for each work stream, and there's very clear papers on each work stream as regards what's going on and what's planned to go on on repatriation of out of area beds and things like that. So that part of it is really kicked off and is very positive. The two areas I think that we need to concentrate on as a board, and one of them I think we're going to talk about at the end of April, is the partnership agreement. I'm chair of that committee. I've not seen a draft yet, so I don't think there's another committee until after the next board. So I'm hoping that virtually we'll be able to review, and the committee members will be able to review that before it comes to the discussion after the boards in April. So that's one area that we've got to sort of get right, and I haven't really got any assurance in terms of what it says at the moment, but I've got a timetable there which says that there should be a draft out by the end of April for us to discuss. So we'll be able to have a good chat about it then, in terms of risk share and things like that. The other area that there's not really been any material progress is the financial due diligence. So there's still this like £6.6 million gap, but apart from that, I think we are ready to go live. But it's quite clear, I know to Pete and I think to me, that there is this gap, and it's reflected in the year-to-date numbers, if you like, the NHS are reporting as variances. So the money is there. It's a question really of getting the right people involved in sort of making the decision to allocate that to us for the period once the go live date occurs, which is all planned for the 1st of July, as you all know. So that's a summary. I don't know if anybody's got any questions.
Thanks. I was going to ask Pete, but Michelle's got a hand up, so we'll come to Michelle first, please.
Yeah, no, just to reiterate about the partnership agreement. Yes, we've got a special board session to go through that after the April board, because we did think that it would be really useful to go through that in detail. So that has been scheduled, but it will be sent virtually around the committee before. It's just been worked through with the partners, because the idea is that the other partners sign it off, so that the actual final version comes to us, as it were. So that is in train. The second thing is about the financial due diligence. I mean, Pete will obviously pick it up, but we've had a couple of conversations with the regional team, which has sort of been a bit helpful and a bit not helpful to have a bit of a conflicting terminology. But we are working through that. What is really interesting is it's really clear in the planning guidance that they should give you the base budget for as a starter. Which is not the case at the moment. So we're still having those conversations with the regional team, but we've also got a couple of conversations with the national team as well, because I wrote to the national teams just to give them a position statement of where we're up to. So we're still predicting going live in July if we square that circle from the finance, and I'm hoping that by then we will have. But it is sort of like one step forward, two back at the moment. But I don't know if you want to add anything, Pete.
I think you covered it really well, Michelle. I think we've had several conversations with the regional team. We've escalated to the national team. You pulled out the planning guidance is very clear in terms of maintaining stability for financial providers. And I think even, dare I say it, the regional team recognise that we're ready to go live and don't particularly see the need for this intensive support offer, because they recognise the only thing that is preventing us going live is the financial gap. Yeah, this might sound like I'm in defence of the regional team. We know that they were waiting for their financial allocation, but we're expecting they would receive that now. So I would hope we can start to make progress or get to, over the next couple of weeks.
Thank you all for that, and thanks, Peter. I think it was a really useful session with the board recently to go through this in more detail, and obviously, as Michelle's already mentioned, we will be having a session after the April board to go through the partnership agreement in detail. Given the time constraints, it needed to be after a board meeting just to get everybody together, but thank you for arranging that. Okay, so we'll watch this space with interest on that one. So if we go to item 15, which is the COVID report, Lynn, and obviously I think since you've written this, there's been obviously a national level change, and perhaps John could give us an update on the second vaccinations as well. So over to you, Lynn.
Yes, thank you, Chair. So as you have just very accurately said, since I wrote this report, the NHS national alert level has been reduced from level 4 to level 3. And obviously that's in line particularly with infection rates reducing, nationally that hospital admissions due to COVID have reduced, and thankfully that death rates have reduced too. So that applies to our area as well. Although there is a slight exception, as you can see in my report, that infection rates in Hull particularly are remaining a bit stubbornly high. Now it has reduced a bit since I wrote the report too. So obviously public health people particularly are paying that attention in terms of sort of the areas where that's occurring, and obviously undertaking sort of plans to address and mitigate that. And I guess it's why the sort of public health messages still very much apply around sort of infection control, social distancing, hygiene, those sorts of issues. So, and again, that's an area that we continue to focus on with our staff as well. Other than that, as you can see in the report, that due to the infection rates reducing, we have no COVID positive patients currently in our inpatient areas, which is great news because that feels like it's a stabilising position now. We have adjusted our cohort arrangements for our mental health and learning disability service users. So we retain some COVID cohort beds at Millview Court, but we've actually reverted some of the beds back to treatment beds for mental health service users. And we're obviously using that because we think it's appropriate given the infection rates, but obviously it's allowing us to reduce our reliance on out of area beds, and you'll see that in the IBR as well. It's reflected in the data. We still are utilising some out of area beds. Some of you will be aware that we are undertaking works to Maester Lodge at the moment, and that's to increase the number of functional older people's beds, again to address pressures that existed before COVID but obviously have been exacerbated due to COVID demand. So that's all going in the right direction at the moment, which is great news. We've touched on already that we are, however, still seeing some operational pressures. We've talked about the significant surge in CAMs, children and young people services. Now, this was a predicted position, but obviously it's not just relating to us, it is a national picture. Talked about that already and the work that's taking place to address that. The other area that we are seeing ongoing pressures is particularly in Scarborough and Rydale. And the reason for that is obviously we've made a step change in terms of how acute hospitals relate to community services. And this is a step change in terms of supporting timely discharge that all systems really want to retain. Obviously, it needs to be safe, but that sort of attention to timely discharge, supporting the community, home first, was the direction of travel anyway before COVID, but obviously, with COVID, that really did concentrate efforts around that. So there's changes to discharge pathways we're planning to keep in place. That means that the demand on our community services remains high in that area, and actually the acuity of the complexity of need that our community team there is working with is high too. So there's lots of systems discussions at the minute around what we need to do more to support our community teams. It's probably the right thing to do, but obviously we need to make sure that our teams are equipped and resourced to do that. So we're doing our own sort of workarounds that too, but obviously working with our system partners as well. Obviously, the report shows that staff absence has been reducing, so slowly still is reducing, which is good news. Our clinical group has been focused particularly on the government roadmap out of the COVID restrictions and how that applies to our clinical guidelines. So that's great news. As you say, Sharon, I'll let John talk particularly about vaccine in a sec. But obviously, we've talked already a bit about the staff health wellbeing agenda. We've been very focused on that through COVID, which I think has been great. And I guess sort of to describe that simply, I think we've been focused particularly on supporting staff, increasing resilience, but all good EPRR guidance and practice tells you that actually the recovery phase of a crisis actually is the most important phase of all. So we've managed the crisis well, but now we need to manage the recovery well. And I think there is a slightly different emphasis on recovery. So it is about resilience, but actually it is, some element actually is removing the stressors as well, or giving time for staff to recuperate from those pressures. So the plan that Michelle and Steve talked about earlier, I think is really key now to us, and obviously that's where our focus of work is. So let John come in on vaccine.
Thanks, Lynn. John?
Thanks, Lynn. So I think just the easiest thing to do, Sharon, will just be hopefully to share a screen. Just give me 1 second. I have the right bit of information up. No, sorry, wrong piece of information. Just give us a second.
Different John.
Yeah, can you see, what can you see now?
Can see a slide that says digital update, John Mitchell.
Yeah, apologies for that. Just I'll stop sharing that. Okay, look, I was hoping to, yeah, there we go.
Oh, we've got a table up now, John.
You got the table up, got there in the end. Okay, so look, this is the table which we run every day. So this is run at 8 o'clock this morning. I know it's a little bit small, but I'll just take you through the figures down the bottom. So you can see First time round, we were at a figure of 83% after we'd completed the first round of doses. And as of sort of 6 o'clock last night, 52% of people have actually had their second dose, and that's 6 days in. So our colleagues are being vaccinated in numerous sites, including by ourselves and the primary care networks, and up in York. So I would have thought by the weekend we'd be seeing figures closer to 60–70%. Just to remember that we vaccinated in Humber over a 3 to 4 week period. So this is where we got to after 6 days. So what we've seen with our booking systems is literally no DNAs, no dropouts. So I'm confident that pretty much everyone who had the first dose will come back for the second dose. We're also hopeful that people who were initially hesitant will come forward for the first dose, and we've managed to accommodate some of those this week. There is some tightness around the supply of vaccine. It's being controlled and managed very carefully at a national and a regional level. So we have to manage the opportunities there. You might want to know why it's 83% and not a little bit higher. There's a couple of issues there. There is some vaccine hesitancy nationally. I think our figure of 83%, and if we include the whole trust, it's closer to 85%, stands as a reasonable benchmark in comparison with everybody else. One of the challenges we have is we know an awful lot of our colleagues in the primary and community services have been done by PCNs. We can't draw that data into our systems, and we do rely on them to self-report that. So we have made changes to our websites, and we're encouraging professional leads and managers to work with them. So we had a long conversation at Workforce and OD last week around some of the issues and how we're supporting vulnerable groups, shielding and BAME colleagues particularly, to get our uptakes right. And actually, the data which we shared with Workforce and OD last week showed that we're benchmarking pretty well. So look, I'm not satisfied with 83%. But it's really pleasing to see that actually we're not having any vaccine hesitancy second time around, and people are happily turning up to get the second dose. So that's the scores in the doors as it is this morning. I think happy to take any comments or questions that you may have.
Thanks very much, John, and thanks, Lynn. So have we got any questions on the paper or anything that Lynn or John have added? No, I think it's a very comprehensive update, as you always, so thank you, really useful to get. Oh, I've got one question now from Peter Barron.
Right, oh, thanks, Sharon. Sorry, put my hand up a bit late there, but it was just on Lynn's area really. I was talking about CAMs and the increased demand on services, and also the fact that we're looking to open up these extra 4 beds at Inspire, which I think is really vital. That we're doing this at this time, but going back to the dashboard earlier, I noticed there were 5 vacancies at Inspire for nurses, and I just wanted to get assurance really that we've got the staff in place, or we're getting the staff in place that are properly trained in these specialised services to sort of deliver you know, the nursing and the other clinical care that's needed in this area.
It's a very good question, Peter. So first and foremost, we're not opening the full 4 beds, we're opening 2 beds. And then we'll make a decision once those beds are open about when it will be appropriate to open the remaining 2. Obviously, what we are balancing here is, you know, significant national pressures. In fact, we had a directive from NHS England, NHS Improvement, around opening any closed beds. So, and obviously our intention always was to open the PICU beds as quickly as we possibly could. Obviously, we will only do that if we consider it safe to do so. So again, working closely with Hilary before we push the button, we'll be checking in, as we have been doing anyway, with the division to make sure that we have got safe staffing in place. What's been great, so it's been a bit of a mixture, Peter, of staff who've actually volunteered to be redirected from less pressurised areas because they do want that CAMS experience. And actually, some of those staff actually do have some CAMS experiences in their past as well. We are using some banking agency and within that, but obviously we've selected very carefully, and we've obviously got a training program in place before we open the service. So it's great that the Orion ward obviously has been open now for over a year. So the skill and experience that we're seeing in that team is good. And certainly obviously given through the year has matured. So there'll be a mixture working in the PICU and Nova ward of existing staff and additional staff to make sure that we are using the expertise in the right way to safeguard quality.
Okay, thank you. Anything else on that, Peter? Happy with that? Okay, are there any other questions? No, thank you both, as I said. So we've been going for about an hour and a half now, so I think we'll just take a short comfort break, if that's okay. So let's come back at 11:10 and start again. So we'll just pause for 10 minutes. See you all in 10 minutes. Okay, welcome back everybody. We've now got apologies from Mike Cook, who's obviously had to leave us as we knew he would. So apologies from this item for Mike onwards, please, Jenny. So if we could move to item 16, which is the strategy refresh. And according to my agenda, we've got a triple act of Michelle, Pete and Lynn. So Michelle, do you want to start?
I will, thank you. Yes, if you're aware, our strategy is really well embedded in the organisation, and we've done quite a lot of work over the last few years in making it our architecture on which to develop our policies, procedures, appraisals, sort of the golden thread that runs through it, underpinned obviously by our values. So we have a quick look at it every year and refresh it because it is embedded. We don't want to make any significant changes, but it actually does come to expire in 2022. So we want to do a co-production strategy like we did last time. So we've got quite a large lead-in period, and we make no excuses for that. We want it to be a collaborative approach to it, and it's really quite opportunistic to start to really look at the strategy now, given the development of the white paper and the integrated care system and the work that we've been doing both in the system and provider collaboratives, and as we move into that commissioning type roles as well. So obviously, because I'm leading the system, I need to just make sure there's some separation. So I'm going to obviously oversee the work with my strategic hat on, but Lynn in a deputy role is going to play the larger part, and Pete is going to, from a planning point of view, is assist that. So what you've got here is the proposal for the timeline. As I say, we do want to make it as inclusive as possible. We are not anticipating changing our values or our overall core mission because they are embedded, and that sometimes takes a lot of time in organisations, and we've built the behavioural framework around those, etc. And one of the things when the regulators come and visit us like the CQC, they do say that staff are aware of them. So it's the other architectural, the objectives, the goals. And the other thing we're working alongside that is constantly reviewing how we monitor and assess our goals in relationship to outcomes. Are they making a difference? So I'm going to stop there. That's a bit about the oversight and the overview. I'm going to hand over to Lynn and Pete just to take you through some of the detail. And I thank them for agreeing to help me with this piece of work. So Lynn and Pete.
Thank you. Sorry, just before you start, Lynn and Pete, thanks for that, Michelle. Can you just, when you're doing your more detailed bit behind this, can you just clarify board involvement? Because I'm sure that's going to be a question from the board about how the board are involved in this process. That would be really helpful if you don't mind picking that up. Sorry to interject, but I just thought if I say it now, you can build it into what you're going to say.
Yeah, sorry, also the governors as well, because the governors have got a large part to play in it as well. Because obviously the part of the governor role is strategic.
Strategy,
so that's what I meant about co-production. But yeah, obviously, of course, yeah. So sorry, over to Lynn and Pete. Thanks, good question, Chair.
So if I just start, I'm sure Pete will add as well. So as you can see from the paper, what we'd actually like to do in the first phase of approaching this is to do, I think, what we're calling a sort of stock take of where we're at with our current sort of strategy and our objectives. So using the data and the information, really, given the year that we have just had as well, it just feels really important to do that piece around sort of understanding where we are with that. And then the plan would be, Sharon, that we will bring that stock take back to the board through the appropriate process, along with a plan about how we're going to take the strategy refresh forward from there, with the detail around who and how we're going to engage, because we absolutely do want, as Michelle says, this to be a co-produced piece. So the timeline you've got there obviously is the overall timeline that we want to work with, but we do want to bring that back to have that sort of more detailed conversation in terms of steps in the process. So Pete, do you want to add to that?
I mean, I think you and Michelle have framed it really well, and I think there's the piece of work to do a bit of a stock take, as you've articulated, which we'll probably take to board in the next couple of months. Timeline looks to bring the strategy refresh to the board next October. Obviously, in between then there'll be a hell of a lot of engagement session that, I mean, I've not discussed this, Michelle, but I suspect using the board time out would probably be sensible to use to actually get that right level of engagement. And I think I'll probably stop then. Happy to, I'm sure between the three of us have to take any questions.
Thank you all. Questions for the team on the strategy refresh? Francis.
You've answered a couple of them, because one of mine was going to be around board involvement, and again picking up on the board timeouts. I think that would be really useful if we could, because you've got the governors built in on the time plan. I can see that. That's really good. So if we could just build in some board timeout discussion times, that would be great. And the only other thing was, it's great we've got the white paper. What about the long-term strategy, long-term plan, and the people plan being kind of into that? I agree with Michelle absolutely in terms of vision, values, etc. They've done a great job of embedding them into the organisation. We don't need to touch those, but we might want to bring in some of the long-term plan, some of the people plan into some of the stuff that we're doing.
Yeah, thanks, Francis. Dean?
Yeah, thank you. Thank you for bringing this. It's useful, isn't it, to be looking at something in advance. It's just a couple of questions or observations, I suppose, that are I suppose are meant to be stimulating in terms of thoughts, really. But so something about calling it a refresh, whilst I understand what we're saying in terms of sort of values, behaviours, those sorts of things sort of being embedded. I just wonder if sort of refresh has the potential to curtail some level of ambition, you know, to think sort of broader and bigger about the potential sort of opportunities. And then there was something just about, in terms of the length of time, that it's good to put the, you know, the planning and preparation in and the engagement. But I'm also conscious that sometimes a long run into strategy can frustrate things that we could exploit earlier, if you like. So on the back of COVID, where we've seen, for example, you know, significant change in the use of estate, significant change in the use of technology, significant change in patient pathways, about how we could develop those further in advance, as it were, of October 22. So it's just some thoughts about that, you know, the sort of language. I understand what we're saying, and you know, given the presentations we've just had on things like the staff survey, some of the sort of insights reports, the performance reports, where we're seeing that it's been a positive journey, and this sort of opportunity, isn't there, to use that as a springboard to go further and faster. And so it's just that broader thought, really. But you know, happy to have that sort of debate and discussion.
Thanks, Dean. Michelle?
You know, that's a really good point, Dean. And this isn't about sort of not allowing us to do the business as normal, because that for me is the business as normal, the people plan, digital strategy, the estates, the work that we've learned from COVID. This for me is about what the organisation's future role looks like. So it's that real big strategic picture. Where do we see ourselves as an organisation being in 5 years? I mean, the people's plan, the digital strategy, the estate are all enabling a piece of work, and we've got individual plans on those plans, strategies that support the trust overall. So for me, this is, and I suppose refreshing, I take your point, it isn't the right word, it is updating, I think, and reviewing the trust strategy. But for me, it's more fundamental about what do we see? Do we see our business continuing to be out of hospital care, mental health? Do we see it continue to be learning disabilities? How do we see the role relationship to provide a collaborative and the ICS? So I think you're right, Dee, but I think for me it's that bigger picture, and I think that's what we tried to do with the first reiteration, and I think we need to build on that. Does that help?
It does, particularly in terms of the ambition. I guess I just question, Michelle, some of the we've traditionally seen things like, haven't we, estates and workforce and digital as enablers, but I think that what we've identified over the last year really is that they've been drivers for change rather than enabling change. So, you know, we sent people home, we gave them technology, and it's actually changed the way that we've done things. And it's just that different sort of context really of sort of exploiting that. I mean that in the nicest use of that word, you know, using it well and wisely, the change that's happened to sort of really improve things for patients, but really reassured by what you're saying in terms of looking at that big broader picture and not being curtailed by language of refresh and refine and sort of incremental sort of improvement, because I think there is a great opportunity in terms of the baseline that we've got, really.
No, thanks. I think that's a helpful discussion, actually. Anything else on this? No, it's useful to have it flagged up early. Thank you all for that. So just so we're clear for the minutes, so the aim, as I understand it, is to stock take, bring that back with the plan to the board within probably a couple of months. if we could work on a timeline for Jenny with that for the actions, Lynn and Pete, that would be good. And if we could also pragmatically just work with Jenny on the dates to get in for board timeouts or board strategy sessions or governors to make sure that we can fit with your timeline. I'm just conscious that times come and go and dates are in people's diaries. So even if it gets cancelled, it may be worth just penciling in some dates for now. So if you could work with Jenny on that, that would be helpful. OK, thank you very much for that. If we could move on then to item 17, which is the operational and service planning. Pete?
Yeah, so obviously this paper was written pre-issuing of the planning guidance, which came out at the back end of last week. So I'm sure we'll be picking that up later on the agenda today. So, we've written this paper based on the guidance we had at the time, which was something that got written to us before Christmas, which summarised some key areas for focus, including workforce and strengthening our local people plans, focus on expansion in mental health and the mental health long-term plan, and looking at building on the development of partnerships and the emerging ICS. Locally, divisional service plans have been refreshed and they're on the intranet, and we have produced a draft plan on the page. But if I could make a recommendation, Chair, now that we've had the planning guidance published, I think it would be sensible to review the planning guidance and review this document and bring that back through the normal governance arrangements. And I'm happy to stop there. I don't know if you want to add anything else, Lynn.
No, Pete, obviously as the paper describes, without the planning guidance, we did feel that we needed, because it's very useful, just to use the sort of operating plan on the page to look back over the last year and given the year it's been. So there's a sort of summary there that's obviously in a text written form, but we've also placed it on our intranet as well, where there's a bit more detail to it too.
Thank you. Steve?
Thanks, Sharon. I mean, conscious this is still a draft and in that kind of stage, but I think just drawing back on what we picked up around recovery. So I think our operating plan needs to pick up recovery, both in its ambition about what it will be, linking in with recovery, but also having recovery as part of our operating plan. So it needs to be one of our objectives for this year will be managing that process and ensuring that we do it for all the reasons that we've kind of touched on. So I think, and I know, Pete, that's in the planning guidance. So as you say, this is kind of the benefit of having being able to refresh that. But I think there's an opportunity there for us to make that kind of front and centre in what we do for the next year.
Thanks, Steve. Francis?
Thanks, Chair. I'd support Pete in it coming back now that we've got the full guidance, so we can update it. That sounds really sensible. I was just thinking, I thought the operational plan on page stuff was really good. I had a look at them on the website. It looks great. I like the way that we've put that stuff in. So just well done to the team in getting that done. It looks really good.
Thank you. Thanks, Francis. Yeah, I mean, there's such a long list of celebrating successes. It's great to see as well. So that's really good to see. So are we taking, we'll take it as an action then, Pete, and then come back to next month's board meeting, which you can revise it given the guidance that's now been received and given Steve's comments and other people's comments. If you bring it back to the next board, it's only a short document anyway, so that'd be really good to receive that next month. So we'll take that as an action then, Jenny. Thank you. So if we could move on to the board assurance framework, item 11. Have we got Oliver with us?
Morning, Sharon. Yes, I'm here.
Morning, Oliver. Welcome back to the board. Good to see you as always. Over to you, Oliver.
Okay. Thank you, everybody. The board assurance framework, obviously this represents the Q4 version for the year, so taking us up to the end of March. As you will notice, there is some significant changes to the format, in that we've now included some of the commissioner risks from the Humber Coast and Vale Provider Collaborative Risk Register. So I suppose, obviously, it hasn't been to any board subcommittees in this format, so I appreciate it's going to be the first time a lot of you have seen it in this context. So it'd be useful to get any feedback today. If you like the format, if it works for the board in terms of its nature and taking the BAF throughout the year, if there's a different way we need to do it. In terms of the overall assurance ratings, obviously we reviewed those as part of the executive management team in March. We've agreed to maintain the ratings as they were from Q3. We've not looked at the commissioning risks having impact on the assurance ratings because we're looking at purely from a provider risk perspective. But that might be something that we need to consider going down the line as well. And I'm happy to take any comments on that today. So as with all anything else, comments on the format would be well appreciated. Any feedback, anything you think we should change or think about including or developing on the document. And obviously, it's just any views generally in terms of the inclusion of the commissioning side of things as part of the overarching document.
Thanks, Oliver. Can you just, before I take questions, just pick up perhaps on the new risk?
Yes, certainly. So in regards to the new risk entries, we've included them as part of the trust-wide risk register as well, just based on their rating. So what we've done is we've pulled out the highest rated risks that currently sit on the Humber Coast and Vale Provider Collaborative Risk Register. So any risks that have a current score of 15 or above, in line with the trust-wide risk register document. So those risks obviously get reviewed by the commissioning committee. They're owned by Mel Bradbury and her team, and obviously informed by our exec management team as well. The view was obviously that we would include them as part of the document, but split them out quite clearly. So we had provider risks, obviously, for the organisation, as well as having that sort of defined section for the commissioner side of things. So although they do sit on the document, we did want to just split those out, and obviously that's why they're under a slightly different heading for each of those entries. In regards to the entries that have been included for the BAF document, obviously we've included the highest rated ones, but anything that's sort of aligned to any of the strategic goals as well. And that'll be an ongoing piece as that risk register continues to develop. Obviously we'll feed it in as part of executive management team's review of the risk register and the BAF, and any additional risks that are coming through that need to be aligned. The view would be that we continue to refresh the document, make sure the actions are completed and updated as well, and that we'll keep feeding in any additional risks that get sort of identified as part of that process to the board assurance framework, just to give that overall assurance rating linked to the provider collaborative risks, that they sit alongside the provider risks, but we are recognising they're linked to our board assurance framework and our strategic goals as an organisation. So, I mean, I think there's no hard and fast guidance around this, and something that we should be doing as an organisation when we're linking in with the provider risk. So we've had to interpret it and bring it into the BAF from our own perspective and how we'd like to do it going forward. So I'm under no illusion that it's likely going to change throughout the year, and we'll get a bit slicker at it and further develop the document. But I think we've made a good start of a 10. And I think obviously the risks that have been identified so far, they are fairly high scored, but I think that just reflects the nature of where we're at currently with the provider collaborative in its early stages. And obviously as that goes on, that will develop as well, and we'll see the changes to those risk entries.
Thanks. Hilary, I think you want to come in.
Yeah, thank you, Sharon. Yes, it's the first time we've seen this, isn't it, as Oliver said, because it's not been to the subcommittees yet. But we did have a long discussion at the commissioning committee about how we would be able to pull together the BAF and link it to our strategic objectives. So for me, this looks pretty good in terms of the way that we're doing it. We're doing exactly the same. I do think that we ought to split it out, though. I think we ought to look at the two documents separately. So we've got a BAF for provider and a BAF for commissioning, to really keep that clear blue water between the two. I think we could otherwise, as we go forward, get a bit muddled with whether or not we're looking at a commissioning or a provider risk when we've got it all in one document. And I do think this demonstrates that it links back to the strategy work that we've just been discussing. The objectives under the commissioning element do need to look different. They don't read across, obviously, from the objectives in the provider. So that's obviously the next piece of work we need to do. And I think once you've got those objectives on the commissioning side of things, then this will start to make a little bit more sense in terms of the commissioning piece. But I think the purpose of bringing it here today was to sort of demonstrate how we were trying to bring that forward, integrate it into the systems we've got as well. But so just be mindful that for me, we've got to keep that clear blue water, and we should keep, for me, the documents as separate as we can.
Thank you, Hilary. Michelle?
Yeah, thanks, Sharon. I think Hilary said most of what I was going to say, really. I mean, obviously, as the owner of the BAF, I mean, it's really difficult, and I think Oliver summed it up. There are no rules in relationship to this, and there's no precedent in which to sort of share experience. And I actually think we've probably got one of the better BAFs, if probably one of the only BAFs at the moment in relationship to the commissioning risk. So I completely support what Hilary said. I mean, and just it is work in progress, but I would obviously like to know what the board think as well, because I do think we have to, as we've always done at the moment with the commissioning, keep the two completely separate and have that Chinese wall between the two. So I think doing it this way allows that to happen, but it will change as we mature and as we develop. But any immediate observations are welcome. But thanks, Hilary, and thanks, Oliver.
Thanks, Michelle. Any observations from anybody? Peter Barron?
Yeah, I'll just say, obviously, the provider collaborative hasn't started yet, and we will not start it unless we sort out the financial envelope. So, in a way, it's not. By the time we actually make a decision, I'm hoping that these red risks on finance will have come down, and if they haven't come down, I don't think there'll be a recommendation to start the provider collaborative on the 1st of July. I just say that I wouldn't be too alarmed by them, because it's our full intention through Pete and Michelle to sort out the financial envelope, bring these right down. So, you know, I like the way it's presented. I appreciate it. Perhaps should be two separate documents, but at least we're getting the board sort of involved in a discussion here and seeing what the issues are. But I'll just say, really, that these red risks will not, you know, will not be there, because we will sort out the envelope. Otherwise, we won't be going ahead with it.
Okay, thanks, Peter. Francis?
Thanks, Chair. I was just going to say, I like, as a start of a 10, it looks good. As Michelle said, I'm sure it will evolve over the year, but at least it gives us a good starting point. And I'll look forward to having a discussion at FIC on the finance ones. But yeah, it looks good. I like what you've done, Oliver. I think Michelle's right. I've not seen anybody else do this kind of thing yet. So again, I think we're ahead of the game. One minor point on not to do with the collaborative bit, but on strategic goal 3, on the gaps in control and the actions. Just, are we going to put any dates on those? You've dated everything else, Oliver, really well. Just wondered if you're going to put any dates on the actions in that one.
That is my mistake transferring it to the document. That we have dates against all of these actions linked to the risk. So I can maybe send a post-meeting note just to give some assurance around this. But there's dates attached to everything. So that's purely been an error when it's been transferred from the risk register into this document. So I apologies for that. That's an oversight on my part.
No worries. Just thought I'd check.
No, that's fine, Oliver. Can we, Oliver, if you just amend that page, Jenny, as an action, Jenny will just circulate that page round everybody again. So strategic goals 3. Dean?
Thank you, Sharon. I've just got a question which is on the risk register that related to the provider collaborative, and I don't know whether to raise it here or if we're having a further discussion on the risk register afterwards.
We will be, Dean. Yes, we're moving on to the risk register.
It just sort of links in, but I'll wait for it in the risk register.
Okay, I'll come to you first on the risk register. No, that's fine. Oliver, I like the way it's presented. I think it's good. It's good to see that it's a live document, because notwithstanding the provider collaborative, we've got new risks on the substantive part of the BAF as well. So with regard to waiting lists, etc., which we've discussed earlier. So it's good to see that it is a live document and it is being used, because Michelle's right, that's not always the case in other organisations that I've seen. So no, it's good. So work in progress, but really good start, Oliver. So thank you for that. Francis?
Sorry, one final point, more for Steve rather than Oliver, I think. On the developing an effective and empowered workforce, a lot of the dates for having completed the actions in the gaps of control are actually today. So hopefully at the next workforce committee, we can pick up on what we've done with those and where we've got to them, Steve.
Yeah, definitely, Francis. Got about 4.5 hours to get them completed, I think. Is that right?
I was going to say, no pressure there, Steve. I'm sure it's all under control, Steve. I'm sure it's all under control. So thank you for that. So if we can move on, still linked with that, but we can move on to the risk register, item 19, Oliver.
Okay, thank you. Yes, so obviously this document will represent the current 15 plus for their current score risks that sit on the organisational risk register. Obviously, briefly touched upon it with the BAF. We have aligned those 4 highest rated risks from the provider collaborative risk register to this document as well. So that takes a total up to 10. The first 6 are obviously the provider natured risks. Obviously, some of these you've seen throughout the year. So we've got WFO3, which is level of qualified nursing vacancies. WFO4 is the retention of the qualified nurses within the organisation. WF10 is retention of medical staffing. FII 205 is the longer term financial sustainability risk, and those entries have been on the risk register for the better part of this year, and obviously we continue to do the work. There's still the significant risk for the organisation, so they are reviewed on a regular basis. They do get discussed at the relevant board subcommittees, but again, obviously they do represent significant risk to the organisation, and sort of they're in line with what we see from other providers as well in terms of makeup of the composition of the highest rated risk. So we're in line with sort of our colleague organisations that were across the landscape with healthcare. WF25 was technically it's a continuation of the risk that did sit on there before. Previously there was an entry that captured consultant vacancies as well as GP vacancies, but I think the nature of those two risks, very different controls in place and different actions that are planned, and obviously a different score linked to those risks as well. So WF25 presents the consultant vacancy side of it. WF26, which doesn't sit in this document, is around GP vacancies. So those risks were split out. They were reported into Workforce and OD Committee as well. And I think it's just to have so we can have really specific controls and actions linked to those separate entries. Ops 11, which is the row 6 on that document, is the new risk around waiting times that we've added, obviously just to recognise the whole trust-wide position on waiting list. Obviously, a lot of work underway. Obviously, you mentioned you had discussion. I know it's a key point that was discussed at EMT when we reviewed the risk register in March. So we've taken this way and added this additional entry. Obviously, this work will, and this particular risk will continue to develop as the work on goes throughout the new financial year. And then the next 4 risks are obviously the specific entries that have been carried over from the Humber Coast and Vale Provider Collaborative. And obviously, as Peter's indicated, these do represent the risk as we currently stand. And obviously, if these risks do not get managed effectively, obviously it's not going to allow for continuation of the provider collaborative in its sense. So these just represent current position, which I would have thought we'll see quite a bit of movement on these as time evolves, but obviously these are where we currently sit. So obviously that's a bit of an introduction. I'm happy to take any comments, any feedback. Obviously this does represent an end of the year position, so we need to do quite a comprehensive piece of work going into the new financial year, particularly into the workforce and finance side of things as we're coming into the obviously new year budget and so on and so forth. So this does represent that end of year position. But as ever, happy to take any comments or any feedback or any areas that we need to amend or improve going forward.
Thanks very much, Oliver. I know Dean's got a question, but I think Steve's probably wanted to comment on something you mentioned, so I'll come to Steve first.
Thanks, Sharon. I think just to expand a little bit on the consultant GP point, which again we picked up at Workforce Committee, but I think that's testament to the really good work that's gone on around GP recruitment. So, a year ago we were at over 30% vacancies for GPs. That's more than half now. So I think the current figure was around about 14%. So some significant work's been done on that, which obviously has lowered the risk overall, and that's why we've separated it out. So I think it's just worth worth explaining that. Thanks.
Yeah, thanks very much, Steve. Dean, over to you for your question.
Yeah, thanks. Thank you, Oliver, once again for the comprehensive review. It was those provider collaborative risks really that I just want to sort of touch on that relate back in again. So on the, I think it's CC1, risk to provider collaborative financial sustainability, if funding from NHS does not equal the budget, and then CC9, the financial allocation from NHS is based on 1819. So with regard to those two, given we're still doing the financial due diligence, I mean, we wouldn't take the risk if that was the case, would we? So we're saying that we won't proceed with the provider collaborative if we're not clear on those risks once the financial due diligence. I just wonder if they're expressed in the right way, because it kind of implies that we're accepting the risk when I don't think we're necessarily at that stage yet. And then related to that is the CC13. Risk to provide a collaborative longer term financial sustainability with an inherent risk of 25 mitigated to 20. Again, if that was the risk that we're facing at the time to go live on the provider collaborative, I guess we would be questioning whether that was a risk worth taking, wouldn't we? So it's just it may be the way that they're expressed on decisions where we're still doing due diligence about, but I'd be worried that we're sort of accepting those as inherent risks with the due diligence, if you see what I mean.
No, I do, Dean. Michelle?
Yeah, no, I think I can see that, Dean, because obviously what we make really clear is we will not go live, or we will not do the provider collaborative if we don't square the circle on the money. I think we just wanted to I think what we're trying to do through the committee and the provider collaborative is to demonstrate the current risks that because we're not shadow live, but we are in the process. We've accepted to do that work, and we've been through a couple of gateway processes. But I think the nuances in the way that it's written in the language. So we probably just need something, which we've talked about, Oliver, just something else to say that obviously we wouldn't do this if the risks weren't mitigated against. I do think CC13 is still an issue though, because I'm not quite sure how we can square that circle. We can have a particularly good idea of going forward what the financial risks are, but that's the success of the provider collaborative, to be honest, Dean. It's how we measure and make surpluses and continue to drive that financial the financial model to benefit the patients and the community. So I think there'll be still some element of that, but I don't think it'll be as high. But I think the nuance is in the wording, so it is a good observation.
Thank you, Michelle. John?
So I accept all the points about the element of financial risk, but I suppose this is just a question, Peter, about quality risks, really. I noticed that none appeared to be emergent, and I'm bearing in mind our own risk register. We talk an awful lot about recruitment challenges, retention challenges. I would have thought as running a provider collaborative, those same pressures will be transferring over in terms of the services the provider collaborative will be overseeing. And I know it's early days, but I'm just wondering at what stage you think they will start feeding in, because if we're just looking at a provider collaborative risk register, which is based on the finance, I'd be slightly anxious that we're going to fall into a trap later on down the line.
It's a good point, John. Michelle?
Again, it's a good point. We're looking at the quality due diligence at the moment, so I think those will continue to, they'll start to, as John said, they'll start to appear as we go through. But the idea is to try and mitigate as much against that before we actually take on board the collaborative. So we're doing the quality due diligence piece at the moment, which includes the workforce retention, workforce data and statistics, etc. Don't forget, at the moment, all we've got is a really small team, and at the moment what we're doing is trying to develop that team to get some more capacity in there. But the two main pieces that we're working through is the quality and the financial due diligence.
Thank you. I think that's a really helpful discussion, and I think we take it in the context of trying to get ahead of the game. But I think they're really good points that people and helpful points that people have raised. So I think that'll help it. Sort of develop as hopefully we move forward with it. So no, good discussion. Oliver, thank you ever so much. I appreciate you coming as always, and we will see you soon.
Thank you, everyone.
Thanks, Oliver. Have a nice Easter when it starts. Thank you.
So if we could move on, please, to item 20, which is the disciplinary case review. Steve?
Thanks, Sharon. So this report was also considered at Workforce Committee last week. So just for a bit of background, which is set out in the report, stems from a tragic case to Imperial College Healthcare Trust, where sadly a member of staff took his own life who was in a disciplinary process. That was a major investigation that took place from that, and subsequently from that investigation there was some principles that NHSI suggested that boards should apply to disciplinary cases that may be happening in their particular trust, and sort of seek assurances that maybe some of the things that happened in that case would be avoided if it was to happen with us. And that was based around 5 questions that they asked us really to consider. So I commissioned a piece of work from someone in my team to review the cases that we've had over the past 12 months. That person was new in, experienced, and hadn't been involved in any of the cases, so could look at those kind of impartially with a view to providing the data in this report. So this report covers that off. Provides, I hope, assurance that the processes and checks and balances that we have in place would, to the extent that we can give assurance around that, would hope to mitigate and make sure that those type of things wouldn't happen here. I think it's worth also just noting for this that, as an organisation, we've had a number of checks and balances in place for a while. So we know in part 2 we consider some cases within that in the closed session. We also, from a scorecard point of view, provide management information to directors and managers in the organisation, and then at Workforce Committee, as part of the Insight report, we note current cases, current suspensions, and so the opportunities there to sort of ask any questions should it occur. So we're bringing this up because NHS have suggested that it's a good thing to do, which it absolutely is. But I just want to give some assurance that I think we had processes in place to review some of these things as well. So I'll stop there and answer any questions that people might have on the report.
Thank you very much, Steve. Mike Smith.
Thanks, Steve. I just want to compliment you on providing this report and the organisation for putting it into the public agenda. I think it's very, very helpful that you've also given the backdrop to it as to what the board receives, because certainly as a board member, I've had a governor inquiry concerning the sort of things that we are assured about or not assured about. And it's very easy to sort of see things and think, oh, well, I wouldn't wonder what they do about it. And I think you've given a really, really good exposition of the transparent process that we go through. Thank you.
Thanks, Mike.
Thanks, Mike. Anything else from anybody else? No, thank you. As you said, Steve, this did go to workforce and was discussed there, so thank you for that. Okay, if we move on, item 21, items for escalation. I'm not aware of any, unless anybody's got any they think should be escalated. No. Any other business? I'm not aware of any. No. Well, in that case, we will close the meeting in public. So we've closed part 1 of the meeting. Thank you all very much for your contributions. I think it's been a really good discussion and some good, papers and some good discussion on the agendas. And thank you all to the people who have been joining us via the virtual link. Really appreciated, and hope you have a good day and enjoy the sunshine. So Adam, please could we stop recording, please, and streaming?